Hello, everyone. Welcome to today's VMR session. We are holding another teaching point recap today and following the habit of first Tuesday of each month. My name is Parisa, and I'm going to be the facilitator of today's session. But our main players are our beloved members, Minahil, Patricia, and Johan. Who prepared 3 cases from the last month's VMR for us, and we are going to reflect on those cases together, and we are going to learn more. If you have any questions during this presentation, please feel free to put them in the chat, and then we are going to address them at the end of those presentations. Just before we start, we have an announcement from the Clinical Problem Solver leadership. Ibrahim, please go ahead.
Thank you so much, Farissa, for the awesome introduction. So hello, everyone. My name is Ibrahim Omar, and I am CP Solver's VMR leadership team member. And I just wanted to tell you all an exciting announcement that we have, which is that CP Solvers is now open to receiving cases through our website. So if you have a case that you've seen, whether at your school or at the hospital, and you'd like to present it on CP Solvers, please do reach out to us on the website. I'm going to send the link in the chat box, and feel free to submit a brief about your case. And one of our team members will be in touch with you, and we'll schedule you for an upcoming case presentation on one of our VMRs. So back to you, Parissa.
Thank you, Ibrahim. I just want to echo whatever you said. I think it's really great opportunity to learn more by presenting a case through clinical problem solvers. Without further ado, let's jump into that. Our first presentation is by our dear friend, Minahil. Please feel free to introduce yourself and share your screen.
Okay, hello everyone. I am Nahid, international medical graduate from the Pakistan, and I'll be presenting the case today. Teaching points. Let me share my screen. Okay, so you guys can see my screen. Okay. So I will be doing the teaching point recap of a case from October 22 that was presented by Vinay, and the case discussants were Ravi and John. So I'm starting with the problem presentation. So basically it's a story of 74-year-old female that presented with a back pain for 4 months that was accompanied with edema, hearing loss, and loss of appetite. So I will be dissecting this history first. So coming towards the back pain causes. So the most common causes of the back pain are like herniated disc, spinal stenosis. Then it can be due to the infections like pyogenic infections, granulomas, or endocarditis or viral. Then in cancer, metastatic bone cancers are like metastatic cancers are most likely responsible for the back pain. Then we have autoimmune diseases that cause back pain. It includes ankylosing spondylitis, the gout, and other than that, we have the marrow necrosis. Moving towards the next our presentation, that was edema. So coming towards its causes, it can be due to elevated capillary hydrostatic pressure, like we see in congestive heart failure. It can be due to increase in the capillary permeability, like in sepsis or inflammation. Then it can be due to the high interstitial oncotic pressure in edema. For example, then we have lower oncotic pressure, that is very obvious in like some liver diseases and nephrotic syndrome. Then lymphatic obstruction due to the lymphedema or some sort of tumor, or it can be the combination of the above, like a patient have a liver cirrhosis with heart failure or nephrotic syndrome with a heart failure. Okay, so next I am moving towards the labs. This patient have basically elevated ferritin, creatinine, LDH, and ionized calcium. She also have anemia, and her HIV and HPV was negative. So I'm dissecting this hypercalcemia causes. So when our patient have the hypercalcemia, next thing we have to look for the parathyroid hormone. So if that is normal, then we have the two causes, that it can be primary or that can be other causes. In the primary, it can be due to the hyperplasia or due to some genes like adenomas. Then other causes can be parathyroid carcinoma or ectopic production. Then moving, if the calcium is high and PTH is like low, Then there can be many causes, like then we have to check for the PTH-RP that is positive in squamous cell carcinoma, renal cell carcinoma. Then we will look for the vitamin D levels. They can be increased in, like, if their patient have the increased vitamin D intake, or there is some produced by some granulomas. Then we have lytic bone diseases that is mostly caused by the mets from the lungs, breast, or myeloma. Other causes we have like milk alkali syndrome, or that's vitamin A, or some medicines can also lead to this, like hydrochlorothiazide or lithium. So moving next, I am giving you guys an imaging finding of the lady. So her CT shows at CT diffuse lytic bone lesion in the skull, and chest CT shows bilateral pleural fusion, pulmonary edema, osteodegenerative changes with sclerotic foci, and axillary lymphadenopathy. So before giving you guys diagnosis, I've combined all the HPI labs and imaging, and I want to ask, like, in the chat, like, what do you think this lady have? Oh, so okay, so going towards the bone marrow, we have, like, her bone marrow shows the 38% plasma cells. Her beta-2 microglobulins were very high, and in the serum protein electrophoresis, we get the monoclonal proteins that were positive for the kappa. So the lady was diagnosed with a multiple myeloma. So moving towards the pathophysiology of the multiple myeloma, what happened in the multiple myeloma, that most of our healthy cells that convert into the abnormal cells, and then they form the antibodies known as M proteins. So what does this do? These M proteins are basically the main culprit, and they will then go and attack your kidneys or bones and affects your body's white blood cells, red blood cells, and platelets. So we have a very good mnemonic for it to remember this multiple myeloma, that is CRAB. A patient will present with hypercalcemia. That patient will have a renal insufficiency, anemia, and lytic bone lesions, you will find out. Then what is the diagnostic criteria for the multiple myeloma? So necessary criteria that is like greater than 10% clonal plasma cells in the bone marrow, or biopsy proven bony or soft tissue plasmacytomas. And with this, we should also have one of the following, that there is an organ or tissue impairment that attributed to the plasma cell proliferative disorder, or there is a biomarker that is associated with the inevitable progression to end organ damage. So next, moving towards the treatment, like, then we have to treat it according to the, like, stage. If that is a solitary plasmacytoma, we prefer like surgical removal. But if that is like smoldering, and then we have to see that that patient is like low risk group or high risk. For low risk, we will just require a follow-up for like 6 to 12 months. But if the patient falls in the high risk group, we have to do the close monitoring for maybe like 2 to 3 months, and then start the treatment. And if the patient is symptomatic, then we have to give him the first induction therapy that includes 3 or 4 chemo drugs. That is like DRD, and then we have to give the DVRD, other combination. And then we have, if the patient even then not get cured, we have to move towards the hematopoietic stem cell transplant. And after that, we move towards the long-term maintenance therapy. So these are the references which I use. If you guys have any question, please feel free to ask in the chat.
Thank you, Minahil. It was a great recap. You take us through back pain, edema, hypercalcemia. We really appreciated time, the effort you take. I just have a small question if no one else has. I was just wondering that you were talking about the biomarkers associated with end organ damage. Could you please elaborate on them more?
Yeah, like the specific biomarkers, we have the multiple myeloma or M protein that can be found in the serum and urine, and most commonly it's detected through the SPAP, serum protein electrophoresis. And the second most common, like, the specific biomarker for is like free light chain, the kappa and the lambda-1.
Oh, thank you so much. It was amazing presentation. We really appreciate it. Now we are moving to our next presentation. Patricia, the stage is yours. Please share your screen and introduce yourself.
All right. Hi, everyone. Patricia. I don't know if you are able to see my screen. Are you?
Yes.
Okay, thank you. So I'm Patricia, a medical graduate from Cameroon, and I'm a proud member of the CP Solver Academy. So today I'm going to do a teaching point recap for you from the case of October 16, 2024. It was a case presented by Dr. Mark Ensling, and the discussion was Dr. Reza and Sharmin. So our discussion started with a 54-year-old woman who developed altered mental status after 24 days of hospitalization. In our CPS website, we have a framework for altered mental status, the mixed mnemonic, stand for metabolic, infection, structural, and toxin. Metabolic causes, we usually have an increase in carbon dioxide or a decrease of oxygen, also a bad liver function. Infection causes, we are divided into extra CNS or intra CNS. Structural cause, we usually have subdural hemorrhage, and toxins, we have opiate overdose or alcohol withdrawal. And our case continue with our patient, which came in with diarrhea due to C. diff and developed polyarthritis. She had high CRP, high ESR, and her seronegativity was negative. She was seronegative. She was placed on high-dose steroid and later on was put on tocilizumab. Due to her declining condition, she has to be intubated for airway protection. Past medical history, she has diffuse large B-cell lymphoma and was placed on CAR-T therapy. Her labs show an increased AST, increased ELT, increased RFOX. Interestingly enough, her BUN was 51 and the creatinine was 0.77. And she had an anion gap metabolic acidosis of 20. But our focus today was about her arterial ammonia, which was elevated at 1400. So the title of our discussion today is hyperammonemia, which is an increase of ammonia level in the blood. Ammonia is usually a neurotoxin which can cause irritability, ataxia, confusion, cerebral edema, and even death. So we'll go through, and in the discussion, we went through the ammonia pathway. The ammonia comes from the protein, which go through, so it goes intestine, liver, and kidney. So from the intestine, we have the protein that we get from the food. The protein gets metabolized into amino acid, which then get metabolized into ammonia via the bacteria which are present in the intestine. Then the ammonia had to travel to the liver when it will go through the urea cycle to get transformed into urea. And from urea, the urea, which is the product that we get from the urea cycle is a block urea nitrogen, which is water soluble, and it can get excreted through the urine via the kidney. So along that pathway, a lot of problem can happen. In the intestine, we can get a high ammonia level from high protein load, GI bleed, increased protein breakdown, starvation, or seizure. In the liver, so once the protein gets metabolized into the ammonia, it has to go to the liver, and sometimes it can bypass the liver. It can bypass the liver either because the liver is not functional enough in case of cirrhosis, like 19% of high ammonia level are usually due to cirrhosis. So when you have a patient with high ammonia level, the first question is that, is there a cirrhosis or a liver failure? So if the patient doesn't have any cirrhosis, the ammonia can still bypass the liver through CIPS or congenital portal systemic shunt. Sometimes people actually get born with those systemic shunt. And the liver can be okay, but you can still have some disorder in the urea cycle itself. Some medication can affect it, like valproic acid, or you can even have inborn error of metabolism. The most common one is ornithine transcarbamylase deficiency. OTC deficiency is pretty common, and it can often occur in adult life. So you can be a young kid and you don't get diagnosed soon enough, and the disease appear when you are adult. So we need some time to think about it. And in the kidney, we can have some urea positive organism like Klebsiella, urea plasma, or E. coli. We can transform the urea back to the ammonia. So to go back to our case, we have high arterial ammonia level. The arterial ammonia was elevated. The LGH was elevated. Our patient was not cirrhotic because we had a platelet function. We have a platelet number of 600,000. She had no TPN, no GIB, no seizure, and she has no shunt on the CT scan. They did like some urea cycle disorder check, and they did not see anything. The urine analysis was positive, but the urea plasma PCR was positive. So urea plasma, a little of microbiology. So urea plasma are usually small free-living organisms. They are too small to be seen in the microscope. They belong to a class of bacteria known as mycoplasma, and they are commonly found in the lower genital tract of healthy men and women. Interestingly enough, they are opportunistic infection, occasionally causing urogenital tract infection. So patients with immunodeficiency are particularly susceptible to extragenital mycoplasma infection. Like those immunodeficiency can be antibody deficiency or organ transplant. Like especially lung transplant patients are very susceptible to a toxicity caused by urea plasma. In our case, the risk factor in our patient was a high dose steroid. She was placed on a steroid for a long time, and she was also on CAR-T therapy. So that's why she was susceptible to get a blood infection from urea plasma. So to summarize, this is a really nice schema from our website. We can see it all starts in the intestine, the protein goes to the intestine, the bacteria metabolize it into the ammonia, then it goes to the liver when it had to get through the urea cycle. Then after the ammonia get metabolized into the blood, urea, and nitrogen, it has to be extracted through the kidney, and at all those stations we can have some problem. So thank you for listening to me. Thank you everyone. These are some references. We have a really nice video with Dr. Reza which explained that cycle, the hyperammonia cycle on the website, and yeah, that's it. Thank you.
It was so good, Patricia. It was a mind-blowing case, and you wrapped it up really well. I personally never heard of this case, and you really wrapped it up really well. And you went through all this ammonia pathway. I was so impressed. Thank you so much. If anyone has any question, please put it in the chat. If not, last but not least, it's our friend Johan. Please introduce yourself and share your screen.
Hello, everyone. My name is Johan. I'm an MG from Cameroon, like Patricia, and I'll be presenting a case, basically a case presented by the Sinal by Timo IM team on October the 26th, and discussed by our team members, Parisa, who is leading the session today, Maddie, and Mariana. So I will start right away. So first, the problem representation. So we have a patient, 77 years old female from the Philippines, with a history of diabetes, PUD, and dyslipidemia, comes to the clinic with 5 days of abdominal pain, with vomiting and diarrhea. Okay, so the patient basically have abdominal pain with accompanying factors. And with abdominal pain, I'll present to you a really good schemas from the CP Solvers themes. But before that, let's go through it together, right? So you first have to rule out referred pain, especially in a patient with multiple risk factors. So you don't want to miss ACS, for example, right? So for referred pain, think above the diaphragm and below the belt, and then miss intra-abdominal causes, so vascular, perforation, obstruction. And after ruling out those can miss causes, now you can follow an anatomic approach to rule out all the intra-abdominal causes possible. So let's go through the CP solver schema together. So first, they referred the causes that are outside the abdomen, right? So referred pain. So above the diaphragm, you can't miss an MI. You can't miss an MI really. You have pulmonary embolism as well. Other causes are heart failure, pneumonia, and now below the belt. So you can go organ by organ. Of course, she's a woman, so you have to rule out ovarian torsion. You also have to think about endometriosis. She has a fever. You have to think about pyelonephritis, the bladder, urinary retention as well, especially at an old age. You have to think about testicular torsion in male, and of course, hernia as well, right? So the second point will be the VPO and the can't miss life-threatening causes of abdominal pain that are intra-abdominal. So first, vascular, think about an infarct, perforation, and especially in a patient with a history of PUD, you really have to think about perforation as well. So what are the signs of perforation? You look at the markers of inflammation, right? Fever, leukocytosis, and also look at peritoneal signs, involuntary guarding, rebound, rigidity. And for obstruction, you just have to know that SBO is way more common than LBO, and SBO present with nausea and vomiting really quickly, and it's generally due to adhesion. So think about a recent surgery or anything that can actually cause an adhesion. And for the third pathway of this schema, we have the anatomic approach. So first, as you know for sure, the abdomen is divided in multiple quadrants. So when you think about the right upper quadrant, what are the organs that are there? So the liver, okay. Is it an inflammation? Is it an hepatitis? Biliary, okay. You have to think about colic, cholecystitis, and cholangitis as well. Epigastrium, GERD, gastritis, pancreatitis as well. Left upper quadrant pain, okay. Um, 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 Splenic abscess or splenic infarct, and lower left quadrant, think about diverticulitis, especially in the patient that old, and other general causes of colitis, IBD, and other infection. Now, for example, with our patient, the patient present with diarrhea, right? It's just an accompanying fact, nausea and vomiting as well. So these are accompanying symptoms of the abdominal pain. The patient might also be jaundice. So if the patient is jaundice, for example, you might think about biliary causes first, before thinking about diverticulitis, right? Because the patient is jaundice. Something is going on there. And the time course is really important as well. So the most common one linked to, for example, meals, you have PUD, you have biliary colic. You can also have chronic mesenteric ischemia, for example, or pancreatitis that are really linked to meals. So overall, let's talk about our case again. So what do we have, right? The patient has a fever, normal heart rate, normal BP, okay? But on physical exam, we have a mild epigastric tenderness, so it's really specific to a region, right? And for the labs, we have elevated WBCs, so an inflammation and maybe an infection, and it's predominantly neutrophils, and we also have an eosinophilia. Other important lab, elevated lipase, but it's not that high, and elevated alk-Phas. CT, we have inflammation around the pancreas. So basically, we have a picture of acute pancreatitis. Since we have 2 out of 3 elements to diagnose acute pancreatitis, the lipase is not that high, so you cannot use it, but you have the pain and you have the positive CT. So you can see that these are the positive signs. Of course, the EKG is negative, for example, and what is not here is basically negative. So here pretty much we have a picture of acute pancreatitis, but we still don't know why the patient has acute pancreatitis. It might be idiopathic, but we have to know. So this is a really cool schema from CP solvers, but I personally don't use it. I'm sorry, Parisa. I get smashed because it's just easy to memorize. So idiopathic or ischemia, gallstone, ethanol, trauma, steroid, microbiology, so infection, autoimmune, scorpion, ERCP, and drugs. overall, and hypertriglyceridemia for the age. So these are the main causes of acute pancreatitis. And in our patient, there is something that is really uncommon. Why is the patient having eosinophilia, right? So this is a big clue, and it just pushes toward infection, right? So what type of infection can give you eosinophilia? I'm asking to the whole group now. So guys, what type of infection can give you eosinophilia? You can unmute. Amazing. Well, thank you, Elena. Elena is 100% right. So parasitic infection can definitely give you eosinophilia. And in our list, we have Ascariasis and we also have Clonochus. So basically, we're one step away of our diagnosis, right? So what do we need to do now? I mean, what do you do when you have acute pancreatitis? Like an exam that can diagnose and treat at the same time. So of course, we'll do an ERCP. And here on the ERCP, they were able to remove a single worm from the biliary tree, and on ultrasound as well, they saw gallbladder wall thickening. So basically, we have our answer, right? So we have acute pancreatitis due to an Ascariasis infection. The worm is there, and we have our final verdict. And regarding this really interesting case, I have some clinical pearls for you. So first, travel history. Remember, the patient is from the Philippines, and the Philippines is an endemic region for Ascariasis. So you have to keep that in mind as well when you're talking with a patient coming from a different country, coming from a different region. You have to know like the diseases that are endemic in this region. It might help you to get closer to your diagnosis. Also, the patient is diabetic and the patient has hypercholesterolemia. So you also have to keep a really broad differential for abdominal pain because you really don't want to miss the can't miss. You really don't want to let your patient have an MI because you think he has Ascariasis. So it's really important to rule out the most important diagnosis first before thinking about this really uncommon diagnosis. And again, eosinophilia in the setting of an infection, it's a really, really big clue of a parasitic infection, and in this case, Ascariasis. So regarding this month's teaching point recap, I think we're all set. Thank you, Parisa. Thank you, Minail. Thank you all. And yeah, that's it.
Wow, Johan, it was so great. It was so amazing. Thank you so much. You teach us about abdominal pain, pancreatitis, and you kept the session interactive. We really appreciate it. Kudos to you all. Minahil, Patricia, Johan. Minahil she's having the step 3 really soon. We really appreciate the time and effort you all make. And thank you everyone for joining today's session. If anyone have the question, please put this in the chat before we are ending the session. If not, I think that's it. Thank you everyone for joining today's VMR. I hope we are seeing you for tomorrow's. Thank you everyone. Bye.